Complications have been really going down. Nevertheless, we all know that they are not zero, and we have to be prepared. And the fact that they go down make us less ready to face them and to deal with them. So in very high risk patients, we can expect and hopefully successfully treat complication. In medium and low risk patients, we should not expect complication, but this is a wishful thinking. I just focus on what I call the hard endpoints. Vascular complication, annular rupture intracardiac holes, coronary occlusion, LV perforation, strokes, and maybe some others that I miss. Vascular complications, they can occur with any valve. In general, the smaller the introducer, the lower the risk. The bottom line is that even when facing the most dramatic vascular complications, such as iliofemoral vessel rupture, abdominal aorta balloon occlusion can control the complication and allow strategic solution. We have to have a balloon occlusion device for the aorta readily available in the cath lab to be utilized within seconds, because these complications, when occur, are dramatic. This is just an old example, but during negotiation of the introducer, there was a laceration of the iliac, big time laceration. This brings to death in a matter of few seconds. You have to insert quickly an occluding balloon in the abdominal aorta, and then you think what to do. But this is the first act that makes you react. Then you put a cover stent, you call a surgeon, whatever. I don't here, we did with a lasso from the other groin, and then we placed a cover stent. But this is a list of a problem. Another complication is low-grade bleeding. This is a very frustrating situation. The patient goes in the room and becomes slowly hypotensive, maybe in the evening. And you may not be able to detect with angiography. You need a CT, and you see a small vessel feeding an hematoma still actively. So this is something to keep in mind. This unexplained hypotension, don't rely on the angiogram, which may be misleading. Annular rupture. Annular rupture is avoided by accurate and precise measurement of the aortic annulus. In some conditions, it may not be possible to obtain accurate and reliable measurements. We have to implant next week some balloon expandable valve, and I got different measurement. One person measured for a 23, one person measured for a 26. This is not common, but is not so rare. Valve exposed to this risk are balloon expandable, valve requiring post-dilatation, valve requiring pre-dilatation, actively expanding valve. We still, in some situation of uncertainty, utilize pre-dilatation balloon sizing. Is an old-fashioned approach, but sometimes can give some information. If the rupture is contained, like in this case, observation or embolization with some coils is the way to go, and the management can be conservative. In other situations, the rupture is so dramatic that there is nothing to do. This is a very tortuous aorta. The pre-dilatation balloon did okay. We even placed 2 Landerquist to overcome this, but when we advanced the valve, maybe we should have selected a different valve, but this was a steerable valve. The forceful advancement broke the ascending aorta totally. The patient, of course, in this situation becomes hypotensive, and he died in a matter of seconds. So this is what is the message? Do not push. Try to find alternate solutions, but forceful advancement is is something that you have to avoid. If annular rupture is not complete, observation and conservative management are sometimes sufficient. In some situations, implantation of a second valve may help. In our experience, it never helped. For massive rupture, pericardiocentesis, immediate OR transfer or surgery in the cath lab should be done. ECMO is the first line, should not be considered because here we are dealing with a hemorrhagic situation. Other oversizing complications are coronary obstruction, AV block, mitral valve injury, periaortic hematoma, septal rupture, and aortic hook rupture. We already saw it. For balloon expandable valve or active expansion, the criteria to follow to prevent overexpansion are avoid more than 10% oversizing. I think, and you go less than 5 or 5% in moderate to severe calcification of the outflow tract, in a shallow sinus of Valsalva, in extreme age, prior chest irradiation, small body size, and bicuspid with dilatation of the ascending aorta. These are all situations that do not demand for oversizing, and if you are uncertain, utilizing a self-expandable valve, it's always a protection as long as you don't oversize with post-dilatation balloon. In situations with severe calcification, avoid the balloon expandable valve. If you're using a balloon expandable valve, perform aortic injection during pre-dilatation and decide size or underfill. Of course, if it's extremely calcified, you have to expect some perivalvular leak. So this is a situation where surgical evaluation has to be taken into account. Coronary occlusion occurs at the time of post-dilatation. The lower the need to post-dilate, the lower the risk. Exception is when implanting a balloon expandable valve. In this situation, valve implantation is practically synonymous with post-dilatation. Any valve which may require pre-dilatation or post-dilatation is exposed to this risk. Nevertheless, we had cases of coronary occlusion occurring next day. So this is not a guarantee the fact that everything goes well and things look fine during the implantation. If it occurs while you are implanting the valve, if the valve is a self-expanding valve, be ready with a gooseneck and pull the valve up. This is a very simple maneuver which really saves lives. If everything is not successful, you have to go to ECMO or bypass if you cannot cannulate or etc. Prevention, we heard about basilica, which is most probably the most elegant way. Other approaches are to put stents, protruding a lot or a little bit. We really do not know. We did a survey. The long-term risk seems to be low, but you know, it's not easy to get good follow-up of these patients. So I think looking for some more elegant solution is better. LV perforation is almost disappeared with the self-pre-shaped wires. If it occurs, it's almost a surgical emergency. You cannot deal like in the RV perforation where watching and pericardiocentesis is effective. ECMO is the first line, should not be considered because I think in the interest of time we can skip about strokes and just state that the protection devices are fine, but they need to be effective and most importantly user-friendly. Perivalvular leak is a disappearing complication thanks to new valves which have a shirt. Nevertheless, if you have extreme calcifications, these are still there, and when you evaluate with the heart team, take this aspect into account. You see from this graph that they went down, but again, when you have extreme calcification, perivalvular leak can be present. So to conclude, the lesson is many complications may be prevented by patient selection and appropriate planning, correct evaluation of the peripheral vessels, device selection, always have a plan on how you manage a complication. The crossover technique saves lives, may not be routinely utilized, but in complex access should be utilized. The radial approach as the adjunctive technique is important and should be utilized, and complications in TAVI patients are unforgiving. Thus always try to prevent them and be ready to deal with them. And most important, you cannot afford to create a second complication while solving the first one. Thank you for your attention.